Hello and welcome, my dear friends from Dental XP. My name is Robert Silva from the Implant Repair Group Brazil, and it's my real pleasure to provide you with this short but hopefully nice presentation. First, I'd like to thank the Salama family and Latanta team for the invitation and Tyler for the technical support. The topic of my presentation today is aesthetic tissue reconstruction around implants, with the special focus and attention to the anterior maxilla where aesthetics is so important. And the lecture will be split in two parts, so I hope you can find your time to see and benefit from both of them. So this is me and my two brothers in arms, Dr. Paulo and Dr. Jolie, in 2004 at a typical Brazilian barbecue, and we were celebrating the end of the very first perio and implant programs that we ever gave together, pretty much the beginning of the Implant Perio group. But much more than the beer and the laughs, as you can see here in this nice picture, what really brought us together was the general feeling that there was a huge gap between implant and perio. And since from that moment, we tried to combine or merge the benefits of the periodontoplastic surgeries into implant dentistry. And that pretty much became the blueprint of our group. That can be observed in these two clinical cases. So, two young ladies with high smile line showing a single 3 to 4 millimeters deep Miller's class 1 gingival recession that is obviously affecting the aesthetics and the smile of those patients. And the standard for us in terms of the treatment of such situations is the creation of an envelope-like flap in the buccal area without lifting the papillas and putting below the gingival margin a piece of connective tissue graft and kind of advancing the flap. And after several months of healing, this is the kind of situation that we can achieve, a perfect matching of the gingival margin, so complete with coverage with a very nice resolution of the deficiencies. But the difference being between those cases is that on your right, the tooth was broken down, so we had it immediately replaced by an implant, followed by immediate temporization in association with the aesthetic tissue reconstruction protocol that we will cover in detail on section 2 of this presentation, but in association in this case with the connective tissue graft that we just described for the other case. And that is the essence of the perioimplantology. So this term, perioimplantology, was coined by our group many years ago, trying to exactly identify those benefits of bringing the periodontoplastic surgery into implant dentistry to improve our clinical results through time. That can also be observed in these three clinical cases that are already finished, in which there is one implant supporter restoration in this area. Of course, those three cases are not perfect, pretty much far from it, but they are acceptable. And you may wonder or ask yourself, what are the differences amongst those three cases? Some reference lines can show the position of the gingival margin and the papilla tips, and those of you who are a little bit more experienced already can tell where the implant is. But much more than that is the understanding that the difference is the beginning of the cases and the journey from the beginning to the end of those cases. So as you can see here, although we had very challenging clinical situations from the start, we could conclude those cases in a very nice way, as you can compare the below and up images from each individual case. So what we did to treat those situations. So in your left, we had a hopeless tooth, but was still present. So we kind of created and submergence of that root, and after a couple of months, we could extract the tooth and deal with the fresh socket. In the right image, we had number 22 already missing, so using the international classification, so the upper left lateral incisor was missing, so number 22, and the healed ridge was treated with the placement of one implant and simultaneous reconstruction of the tissues that were missing. And on the right, the malpositioned implant was removed and reconstruction was performed, and later on one implant was placed in that area. And pretty much all those situations, although the beginning was not so good, we could manage the case in such a way that in the end, respecting the challenges of each individual case, we could get very much nice clinical resolution of those cases. But much more than asking the difference, we can ask ourselves what are the similarities related to the treatment of those cases. And for us, this is what's similar. It doesn't matter how you get a clinical case. Our hypothesis is that the timing of implant placement should not interfere with the final outcome, as long as we follow those three very important principles and pillars of the aesthetic peri-implant excellence, which are three-dimensional implant positioning, aesthetic tissue reconstruction, and prosthetic management. So implant placement, of course, is a surgical procedure, but it's essentially a surgical step of a restorative treatment, and the correct three-dimensional positioning of the implant is non-negotiable. Today, there is absolutely no excuse for one implant to be malpositioned. We may do it freehand, of course, especially at single gaps following the adjacent references, but conventional or computer-generated surgical guides are very welcome to assure that the implant is well placed. Bone and soft tissue grafting are almost always required to reconstitute a perfect volume around the implant, and that helps to match the pristine natural architecture of the adjacent tissues. And correct development of emergence profile will provide the final touch to this algorithm. So ultimately, this is what peri-implantology is all about. That in the end, we have an almost invisible implant supporter restoration, where at the so-called transition zone at the cervical region, the natural architecture is mimicked and the peri-implant mucosa is protruded in relation to the cervical region of the restoration. So after this small introduction, I'd like to show you the decision trees that we use to address those clinical situations. When the tooth or teeth have already been lost and we have to deal with the already taken place restoration, the name of the game here is regeneration. Or when the tooth or teeth are still present and we have the opportunity to have them removed and manipulate the fresh socket healing. And here the name of the player is preservation. So my dear friends, as I said before, it doesn't matter how you get the clinical case. What is really important is that we follow those three pillars, and one of the most important of them is placing the implant in the proper position. So this is key for the final clinical outcome. But I have no doubt as well that it's much easier and less challenging for the clinician to regenerate from the inside, and that is called preservation, because we have all the natural architecture to perform this preservation or this grafting from the inner part of the socket, as opposed to performing the external compensation, which is placing the bone grafts and the biomaterials in the outer side of the bone that has already taken place. So pretty much it's easier to perform like that, and this is why we're going to talk so much about early implant placement in the second part of my lecture as well. So let us explore the menu here. Simultaneous or staged approach at the healed sites, and socket preservation or immediate implant placement at the fresh sockets. First, the healed ridges. The staged approach stands for rebuilding the area several months prior to the implant placement. Whereas simultaneous approach means that the implant and reconstruction are done at the same surgical appointment. So, when to do what? To answer that question, we must rely on the answer of another question which you can already see in your screen. Is it possible to place an implant at the proper three-dimensional positioning despite the tissue deficiency? If your answer is no, of course the staged approach will be the right shot. However, if you say yes, the simultaneous approach is very interesting to be used. So in this situation, the simultaneous approach, so in that case, in the simultaneous approach, the clinical and tomographic evaluation should tell you what's missing, and from that point, you must define the correct surgical protocol to reconstitute what's missing, sometimes applying only the soft tissue augmentation, sometimes bone augmentation using the biomaterials, and very often using both hard and soft tissue augmentation at the so-called combined approach. Let's see this clinical condition to start with. Now let's see this clinical situation to describe how we manage the simultaneous approach. Here, the patient presented himself 6 weeks after the tooth was lost traumatically in a bar fight. So this case is also very interesting. I like it so much because it resembles that clinical scenario where you do have the opportunity to extract the tooth and passively wait some weeks before you do the so-called early implant placement. Here, as you can see, the socket entrance was already closed by the soft tissues, which are in its final stages of healing, and the radiograph shows that no bone is formed inside the socket due to these early stages of healing. So because the socket entrance was closed, we have no other option but to raise a big flap in many cases like this one to include a vertical releasing incision to better expose the surgical area. Please observe that the buccal bone at this stage was completely lost and the implant was positioned inside the socket walls in a very nice positioning, but all threads of that implant is completely exposed. So now we have to perform the contour graft, which essentially means that some particles of autologous bone which is scraped from the adjacent area will be positioned on top of the implant in such a way to foster the regeneration of that area, but pretty much also including the biomaterials of your choice. We like the bovine mineral, the xenograft, so bios particles, because it's long lasting, so it resorbs really slowly, and it provides a good osteoconductive to the bone that will grow around the particles of the xenograft. And we cover the grafting material with a double layer of collagen membrane. A thick connective tissue pedicle was rotated from the palatal area to further bulk up the buccal region, followed by tension-free flap closure. 6 months later, the second surgery was performed to attach the healing abutment, where it's possible here to observe a complete resolution of the dehiscence-like defect, especially when you compare the situation before the surgery was performed. However, the thickness of the buccal bone could have been a little bit better, and this is why our technique was improved through time. And as you can see here in this more recent case, the contour graft is done in a much more efficiently way, leading to a beautiful regeneration in the buccal aspect, as you can see in the tomographic view. Nevertheless, this is the final clinical outcome, showing a very nice resolution of the clinical case, that we can observe an excellent volume and integration of the soft tissues at the transition zone, as well as a perfect restoration matching. This is the comparison before and after, and most important, the stability after 5 years. And after 10 years, we still have a very nice and aesthetic, stable clinical outcomes, both from the clinical and the tomographic view, At this point, I don't think the bone will go away anymore and the tissues will be pretty much stable through time. This is Dr. Osvaldo Scopin, the prosthodontist of the case, who worked with us in this beautiful situation. But what about this, when the patient shows up without the available bone to place the implant? We just don't have other option now but to do the staged approach that aims to reconstitute the ridge prior to the implant placement. Ridge augmentation is not a technique, but it's a clinical objective. And the objective of the surgical procedure is to regenerate a horizontal and a vertical volume of bone that is now adequate for the placement of the implant into this regenerated bone. We hope to have a very hard bone that can be drilled, and you can see the bleeding showing the bone is alive. And we hope that the implant will also integrate and will provide the support for the soft tissues and live with that for a long period of time. In terms of clinical techniques, there is a big range of possibilities, all of them with its specific list of advantages and disadvantages. But I have absolutely no doubt that the two most widely used options is the autologous bone block and the guided bone regeneration, where a membrane is placed over the defect protecting the particulate bone graft and the clot. Our choice is always the guided bone regeneration because we understand that this approach is much more versatile, in which the membrane can be applicable to any kind of configuration that favors the osteoconduction and vascularization, which make this procedure much predictable in terms of comparison with other techniques. However, being predictable does not allude to being easy. As a matter of fact, this is a very sensitive clinical procedure in which anything can go wrong. So the key here, as stated by Dr. Carlo Tinti and Stefano Parma Benfenati, guided bone regeneration and predictability relies on a strict surgical protocol. So education and training is essential to development of the skills necessary to perform this kind of procedure. A lot of steps are very important and key to define the best strategy to treat this kind of patient. The biological principle behind guided bone regeneration is the osteopromotion, and that stands for the placement of a barrier membrane covering the defect that will protect the clot and the graft material and allow for a selective cell repopulation from the endosseous and sometimes periodontal ligament, and of course preventing the undesired cells to take part in the healing process. Different membranes can be used here, like the non-resorbable titanium reinforced polytetrafluoroethylene, different kinds of resorbable membranes, most often natural non-cross-linked material, and sometimes we can use the cross-linked membranes that are a little bit stiffer. Synthetic biomaterials or membranes are not so much popular today, but may also be used as an alternative. Titanium meshes are the natural alternative for those who like to use the titanium reinforced polytetrafluoroethylene material, and that seems to work pretty much well. But in order to fulfill the concept of the guided bone regeneration using the titanium mesh, we should cover it with a collagen membrane that should be adapted on top of it because the titanium mesh are perforated, and that would allow the cells from the soft tissues to participate in the healing process. What membrane should be used in each clinical situation? So according to our decision tree, the membrane selection is based on the site classification, and there are basically two kinds of defects, the vertical and the horizontal defects. The first is characterized by a curved line connecting the two adjacent bone peaks around the defect to be treated. That means that the adjacent bone peaks are more coronal in relation to the base of the defect, And a further important information here is that the predictability of the vertical regeneration matches the line connecting the two bone peaks. And we have also the horizontal deficiencies, in which there is a straight line connecting both adjacent bone peaks all the way across the defects. When we're talking about horizontal deficiencies, we can further subclassify those deficiencies into favorable and unfavorable defects, and that is classified using the tomographic evaluation. The favorable defect is that one in which the medullar bone is present between the two cortical plates, whereas the unfavorable bone, also known as knife-edge defect, the cancellous bone is not present, and both plates are kind of merged together. It is at the medullary spaces that we find the precursor cells, the blood vessels, and the growth factors, which are necessary to foster the bone regeneration. So, in this decision tree, the titanium reinforced polytetrafluid membrane is used to treat the vertical defects, and a non-cross-linked collagen material is our selection to treat the favorable horizontal deficiencies. As the first option to treat the unfavorable defects, I always prefer the collagen membrane. However, sometimes it's very difficult to stabilize this kind of material using tacks, because sometimes we don't find the best spots to place the tacks. Because of that, it's very frequent that in these situations, the unfavorable horizontal deficiencies, we also use the titanium reinforced barrier membranes that are much easier stabilized using mini screws in the adjacent area. Irrespective of the material you choose, the bone graft material is always the same for us, and we use a 1:1 ratio of autologous bone chips and the xenograft. The autologous bone provides the biological potential for the regeneration associated with the cells and growth factors that comes along, while the proteinized bovine bone entails less morbidity because we have to harvest less amount of autologous bone from the patient, as well as it seems to improve the quality of the regenerated bone in terms of the stability of that bone, because it's a little bit harder and seems to be more stable through time. Exogenous growth factors are very interesting to facilitate the initial bone formation by fostering the formation of new vessels and to promote chemotaxis, migration, and proliferation of multiple cells related to the healing cascade. So we like to use the blood-borne concentrates, which are very inexpensive, easy to use, and very good for the soft tissue healing, and also facilitate the handling of the bone graft using the so-called sticky bone, which is very easy to be used. So as I mentioned before, several topics are very important to achieve the clinical success in terms of the guided bone regeneration technique, which is very tricky. So a lot of steps have to be covered, which today I was not able to talk to you about. Today I only spoke briefly about the decision trees in terms of the membrane selection and the kind of bone material we use. However, all those details, from the incision to the suture, will be completely addressed at the next New York Regeneration Summit in October, which I will have the chance to share the stage with so many important names of the regeneration world. So please book your presence there, and I'm pretty sure we're going to have a very nice discussion day in that summit. So if you follow those principles, it's possible to successfully and predictably treat horizontal and vertical defects, both the maxilla and the mandible, anterior and posterior. Here you can see the horizontal defect being treated at the anterior maxilla, posterior mandible, and anterior mandible. And this is a small video trying to demonstrate how the horizontal deficiencies are treated in our protocol. First, a crestal incision is being performed here, all across the defect. So it's very important that the blade touches the bone. And 2 vertical releasing incisions are performed. There is some criteria to where to place these vertical releasing incisions that I will cover at the Summit New York Symposium. The mucoperiosteal flap elevation is performed in such a way that all the soft tissues are detached from the underlying bone. Sometimes it's a little bit tricky to do that because of the irregularities. So both from the buccal and from the palatal aspect, we must raise the flap and completely visualize the anatomy of the bone that should be treated. Here we are just putting aside the incisal nerve. Sometimes we don't have to cut it. It's also something that I will be covering with you at the summit. The tooth is now being extracted and the socket being corrected. All the soft tissues has to be removed from the surgical area. Decortication is a very, very important topic, and then can be done in multiple ways. Here I'm using the piezo to cut through the cortical and facilitate the migration of the vessels, the cells, and the growth factors coming from the medullary spaces. The resorbable membrane was cut, trimmed, and now is being adapted and tacked in the palatal area using these special tacks. And now the LPRF was cut into species and now is being added to the mixture we use, which is autologous bone and the xenograft, as well as the liquid fibrin is being added in such a way that after some minutes we have the sticky bone, which is much more easier to be adapted in the area. First, we use it in the palatal area and later on in the buccal, recreating the shape and the volume of the bone that we desire to have to our patient. So take your time doing the reshaping of the bone. And now the membrane was positioned, covering the bone graft, and some extra tacks are being adapted in such a way that the bone material just can't move around. So it's very important that we create a very stable synergy between the membrane and the bone grafting material. So the periosteum was cut very shallow, and this kind of movement that you are seeing here, like a shaving motion with the back of our blade, cuts through the top tissues, and we have a very, very passive flap that will be conadvanced. The fibrin is being placed to help the healing of the soft tissues, and this is the most important suture in this kind of technique, which is the deep horizontal matrix suture, which will bring the flaps in the coronal direction, really putting the connective tissue from the palatal flap and the buccal flap in contact, at least 3 to 4 millimeters. This is very, very key to have this kind of closure in such a way that we don't have a closure with the margins connecting each other. So this kind of situation will help the maintenance of the soft tissues to be closed in a very, very nice way. Some extra simple sutures, interrupted sutures, are used there just to seal the area, and probably you're going to have a very, very nice clinical outcome. What about the vertical deficiencies? So these are some of the deficiencies that we can treat in the vertical direction. On your left, the anterior maxilla was treated, and here you can appreciate more than 12 millimeters of vertical ridge augmentation. Here, the posterior maxilla, again, a very, very nice reconstitution of that area, and this is case also associated with the sinus grafting, and you can appreciate here the volume of the bone that we were able to regenerate. The anterior mandible, again, a very tricky area because of the release of the lingual flap, which is very difficult to be performing in this area of the mouth, in the anterior zone. But nevertheless, we were able here to reconstitute the region in the perfect way. And the posterior mandible, that many people consider to be the most challenging area of the mouth, but pretty much it's very clear for us that it's not so challenging if you understand how to manage, the posterior mandible in a good way. Here you can appreciate the final outcome of a very large deficiency, and the CT scans also shows a perfect reconstitution of the posterior mandible in a good way. This is a very old movie trying to describe how we treated this kind of situation, the vertical deficiency. So the crestal incision was performed, the vertical releasing incision at the mesial aspect of the adjacent tooth, and from the lingual aspect as well, and the mucoperiosteal flap elevation is being performed here, both buccally and from the lingual part. So you can see here the both flaps are elevated, but the lingual flap has to be further detached, and we use it in this case, this kind of technique, which a wet gauze was placed below the margin of the flap and was pushed inside in such a way that the fibers of the myelad muscle was open in such a way that we could have better visibility of that area. Please observe that the flap is now being released, and this is a further technique that I learned from the Dental XP webinars from Dr. Michael Picus, using the finger to detach that area. Today I don't use that pretty much. I'll be discussing the way I do it today in the summit seminar that we're going to give in New York. And you can see that the lingual flap is completely mobile and no bleeding, nothing is happening here. So it's a very easy way to detach the lingual flap. Buccally, we must cut through the periosteum, taking care of the mental nerve, of course. It's a very shallow incision, and again, using the back of the rubber blade, we shave the first incision, and now we can pretty much obtain a very elastic tissue to cover completely what we're going to do now. So this is the auto chip maker, a special burr that collects some chips of the bone in the posterior region. So today I don't use the saline irrigation anymore because you can see here that some particles are lost. A scraper can also be used, and here I'm placing the tenting screw, the vertical tenting screw, as a reference for the placement of the membrane. What is important here is that the head of the screw is lined with the bone peak adjacent to the last tooth. The decortication here has been performed using burrs, so it's a very simple and quick way to perform it. So you can see the bleeding coming from the medullary spaces. The membrane was trimmed and now is being positioned here. And this is the way we very easily adapt and stabilize this kind of membrane using auto-fixation mini screws. This is Profix, one in the mesial and one in the distal area. So it's very easy to place this kind of devices in this area because the screws are self-tapping, so don't have to perforate it. It's very easy. Now the bone material is being positioned below the membrane, first on the lingual part, having the membrane as a reference for us, and then we place the bone graft in the buccal area. Because we have the tenting screw, it's very easy to adapt the membrane on top of that. So using a plier, as you're going to see in a moment, Now the plier is used to really push the membrane on top of it, and all the material will be trapped inside or below the membrane. Some screws are being positioned here to really stabilize the membrane. Now we clean the area, and some fibrin membranes are being positioned on top of the titanium reinforced membrane in such a way that it should protect the membrane and foster a very nice initial healing of the soft tissues. So I really like to perform this kind of association, not to really improve the bone, but pretty much to help the healing of the soft tissues. It's very easy to use, as you can see here in this video. Now the flaps are being positioned, and the horizontal metal sutures are being placed in such a way that the flaps are really well positioned, and the connective tissue part of both flaps are connected to each other in such a way that we have a very nice adaptation of the flap, and that is followed later on by single interrupted sutures to seal the incision line in such a way that we can expect here a very nice healing of that area. So my dear friends, I hope you have enjoyed this presentation, and you can find your time to see the second part of my presentation. So this is the implant repair group as we are today, and these are our contacts, and I thank you very much again for your time seeing this presentation.